So, good evening, and thank you for joining us for our October My Macula and Me webinar. I'm Ed Holloway, and I'm the Chief Executive of the Macula Society. And tonight we'll be exploring certification of visual impairment and its vital role in supporting people with sight loss. And we're really pleased to be joined by Professor Omar Mahroo, a leading expert in this field. He is a consultant ophthalmologist at Moorfields Eye Hospital and St Thomas's Hospital, where he specialises in inherited retinal disease. He's also a professor of retinal neuroscience at University College London and chairs the UK CVI committee. And tonight he'll be taking us through the current certification process and the real challenges faced by both patients and clinicians and how the system is evolving. Drawing on his latest research, he'll explore practical improvements that can make certification more accessible and beneficial for everyone that needs it. If you have any questions, if you add them to the chat as we're talking, and then we'll ask them after Professor Mahroo has presented. So thank you again for joining us this evening, and I'll now hand over to you.
Great, thanks very much. I'll just start sharing my slides. So good. So hopefully you can see that. I should say at the start that these slides are kind of a bit more for me than necessarily for you. And I know we have people with visual impairment, so there may be stuff that's a bit difficult to read on the slides. But I'll talk through most of it, all of it, and if there's anything, any questions, I'm very happy to answer questions either as I go along or at the end. And I should say that although I'm chair of the CVI committee, so I'm a consultant ophthalmologist, I'm a retinal specialist at Moorfields Eye Hospital and St Thomas's Hospital. I specialize in retinal disease and now increasingly mainly see inherited retinal disease, so genetic retinal disease. I don't see as much AMD as I used to. I've kind of specialized in inherited retinal disease, and half of my time I spend doing research to try to better understand those diseases, better diagnose those diseases in the hope that we'll be able to develop better or any treatments, efficacious treatments in the future. I'm also involved in the National CVI Committee and with the Royal College of Ophthalmologists CVI office, which is at Moorfields. I've sort of helped with various things over the last few years, and now I'm chair of the committee. But a lot of what I'll talk about is from the kind of ophthalmologist point of view. So although Ed gave me a great introduction there, a lot of the processes and what happens after the CVI, there are people who know far better than me, our eye clinic liaison officers and others who could probably speak about that better, but I'm happy to answer questions as we go along. So with that in mind, I just want to acknowledge a bunch of people here. I won't have time to read out all their names, but our fantastic ECLO Eye Clinic Liaison Officer team at Moorfields, and there are fantastic ECLOs all over the country. Royal National Institute for Blind People, Kathy Burke, who coordinates ECLOs from there, the certifications office at the Royal at Moorfields Eye Hospital, the Macula Society, this very society that has kindly funded a few of my PhD students as well, and various other people who are integral to this, and many others who I haven't even put on this slide. And also just to say that there's a couple of recent publications, well, one's from a few years ago, and there's another one more recently that we published in the journal Eye, which is the journal of the Royal College of Ophthalmologists, but they're open access. So if you, I won't cover everything in this talk, but if you wanted a bit more information, there are some links there, and I'm also happy to send these slides to anyone who wants them. So this is what we'll try to go through in the next 25 minutes or so. A bit of a background to the CVI, the Certificate of Vision Impairment. What are the leading causes of vision impairment in England and Wales, in the UK? An interesting piece of work we did a while ago to look at the effect of the COVID pandemic and COVID lockdowns on rates of certification, and then some current challenges and a few words about the future. So by way of introduction, what's the Certificate of Vision Impairment for? Well, this is the text that's on the current Certificate of Vision Impairment, which tells you it has three main functions. It qualifies you to be registered with your local council as sight impaired or severely sight impaired. It lets your local council know about your sight loss. They should contact you within 2 weeks, ideally, to offer registration and to identify any help you might need with day-to-day tasks. And the CVI also records important information about the causes of sight loss. It helps in planning NHS eye care services and research about eye conditions. So the certificate, in the end, it's just a certificate. What can it do? It can be a way of enabling access to further support that can often make a huge difference to people's quality of life. So the two basic purposes of the CVI, and sometimes they slightly conflict with each other, but they should be in harmony. The main purposes are, one, to facilitate access to relevant support, and many people will be aware there are two levels of CVI, Certificate of Vision Impairment. There's sight impaired, SI, or severely sight impaired, SSI, and obviously you have to meet different levels of vision impairment to be eligible for one of those categories. It has to be signed by a consultant ophthalmologist, although I'll talk a little bit later about how in Wales, in order to deal with a problem of a big backlog in CVIs and many patients not having access to a CVI, they have accredited optometrists who are able to sign off on a CVI, and I think that's making a big difference there, and more data will come out soon to show. I think that's the case. The form gets copied to your GP, your local authority, and to the certifications office, which is the Royal College of Ophthalmologists Certifications Office, but it's based at Moorfields Eye Hospital. And they get a copy of every CVI if the individual's consented for a copy to be sent, and then they log the data, and then it gets, the actual CVIs, the actual forms get destroyed after a year because the data is fully anonymized, but it allows there to be the Department of Health and, in fact, the public to see what the major causes of sight loss are and how they might be changing with time. So that brings us to the second purpose of the CVI, is to provide information on trends in vision impairment. So it's one of there are different ways of measuring how much sight loss there is in the population due to different causes, but one key way is the CVI. Because the cause of sight impairment is recorded on there, we can get an idea of which are the biggest causes of sight loss. Are they getting less with time, or are they increasing with time? Or where should eye services, obviously there are finite resources, so should they be concentrated on in some areas and maybe less, there's less need in other areas? And also in terms of stimulating research, what are the big causes of vision impairment? There may have been big causes of vision impairment that now we've thankfully pretty much got rid of in the UK, some of them from decades ago, and so maybe there isn't so much research or service provision needed for those causes, but those other rising causes or persistent causes that affect so many people, then maybe that's where resources should be allocated. So just a little bit of history. Some people like history. Brief timeline. The first ever census was, the census we have in this country every 10 years was in 1801. But in 1851, that was the first census that included information on disabilities, including blindness. So that was the start of collecting data on how many people are affected by vision impairment in this country. In 1920, there was the Blind Persons Act, which entitled people to statutory support, and a register was kept. So that's the beginnings of a register of how many people there are who are sight impaired. There was something called the BD8 form, which some of my older colleagues and our older patients, older individuals may remember. And in around 2005, but 2007 in Wales, this was replaced by the Certificate of Vision Impairment, which is the CVI form that we have today, which has been updated and is going through a process of update right now as well. So that's the CVI in a nutshell, some history of the CVI. What are the leading causes of vision impairment? Well, we can get that from CVI data. And I have here plotted, and again, it may not be easy to see, but I'll talk through it. But these are the causes of uh, sight loss as recorded in the Certificate of Vision Impairment over the 10 years up to 2019. And why we stopped at 2019, because then in COVID, and I'll talk about that later, the numbers all did funny things, obviously because there were lockdowns, and so that what was happening during COVID wasn't necessarily a true reflection of sight loss in the country. But if we go for that decade from 2009, 10 to 2019, the biggest cause by far that dwarfs all other causes is age-related macular degeneration. And then, and if you can see that, that's the top line here. And then we have a bunch of other causes here, including glaucoma, diabetic eye disease, and some other conditions. If we exclude AMD, just so we can see what's going on down here, we can see what are the other big causes of sight loss in England and Wales, this data refers to. And the biggest cause after AMD is glaucoma. That's the orange points here. And then we have diabetic eye disease was the next biggest cause back in 2009-10, but with time that seems to have gone down. But and now the next biggest cause is hereditary eye disease, which is mostly inherited retinal disease, so genetic problems within a single gene, any one of a few hundred genes, spelling mistakes in those genes that give rise to a usually progressive and unfortunately untreatable vision problem. So that's kind of our third biggest cause now. So it's not good news that we have any vision impairment, but one kind of good news story is that diabetes as a cause of sight loss has kind of not increased over the decade. It may have even fallen, although this is probably an underestimate. All of these are probably underestimates of how many people are actually affected by sight loss related to these conditions. But although the number of people with diabetes has gone up, sight loss from diabetes hasn't gone up so much. And this is partly because we've got better ways of treating diabetes than we did have 10, 15 years ago. We've got better treatments for diabetic eye disease, like anti-VEGF injections, many people will be aware of. It is turned out to be a really effective treatment for diabetic macular edema. And also, we have a very good screening program in this country where every person with diabetes who's above the age of 12 gets photos of their retina taken once a year or once every couple of years now, and if there's any signs of sight-threatening disease, then they get referred to the hospital so that they can be treated early, and that's made a huge difference in preventing blindness due to diabetes. This was all ages. If we just take, and that's just highlighting, yeah, those two causes I talked about, hereditary eye disease, much which is inherited retinal disease, and the diabetic eye disease, which has thankfully kind of gone down sort of over that decade. If we just take the working age, which is 16 to 64-year-olds, that's how people work above 64 and might work even below 16, but that's kind of how we define it for these purposes as working age. Then the biggest cause is obviously not age-related macular degeneration, because by definition that tends to affect the elderly, but the biggest cause is hereditary eye disease. I've now made that confusingly blue instead of red. That's the biggest cause of vision impairment in the working age, whereas diabetic eye disease, which is these gray triangles, as we said, hasn't increased over the decade. In fact, it's maybe gone down a bit. In children, these are the causes. Again, I'm not going to go through this in detail for time, but disorders of the central nervous system, which means the brain, but includes the retina as well, and the optic nerve, are big causes of sight impairment certification and severely sight impaired certification over the last, 2009 to 2022 is the data here. If you divide it up in terms of condition, then still hereditary eye disorders, inherited retinal diseases are the biggest cause for children as well. Next, just if we move beyond 2019, what happened during the COVID pandemic? So we were quite interested to, obviously, we know COVID had a huge impact on healthcare. There was the direct effect of COVID, which caused a huge amount of morbidity and mortality, people getting sick, and unfortunately many people dying as well. Also, there were indirect effects of COVID. So because of the lockdowns and because of the health, resources being diverted to COVID, then there was maybe a backlog for other conditions. So there were many eye patients that weren't seen during the first lockdown. And so we were interested to see, did that have an impact on certifications? And so here, and again, don't worry if you can't see this easily, but I'll talk through it. But here, to work out what's related to COVID and what isn't, because there are fluctuations year on year and month by month, you kind of have to look at the few years before COVID. So we did that here and looked at 2017 to 2019, and then compared that with 2020 and 2021, which were the kind of COVID years. And here plotted is the number of certifications received by the certification office here at Moorfields every month during 2017, 2018, 2019, and you can see it kind of goes up and down a bit. There was a blip in August 2018 where it went up, maybe coinciding with an updating of the CVI form, but it kind of averages around 2,000 or so per month, and that was the same in 2019. And then in 2020, from March to April, you see this greater than 70% drop in certifications. And if you remember, what was happening for those 3 months was the first national lockdown. So immediately, unless you had sight-threatening disease, appointments were being postponed. We were having to go through all our patient lists and trying to work out which patients needed to be seen and which patients we could postpone, because we're trying to protect people and stop them getting COVID, but we also don't want people to lose their sight. But it meant that people lost access maybe to support services. So those people, we wouldn't expect the rate of, vision impairment to have changed. So obviously people aren't getting certified, and because the certification is important to access other support, then potentially this was quite a negative effect of that first lockdown, when there was a dramatic fall in certifications. Then it went back up, and then in subsequent lockdowns, you might remember there were two more. We didn't see such a drop. We saw a little bit of a drop, but not much of a drop after that. So it's as if we'd kind of sorted things out and had new ways of working, so that the certifications, those who needed certification, we had ways of doing that even in the other lockdowns. This is just another way of showing the same data. We kind of averaged every month from 2017 to 2019, and that's this bar, that dashed line, horizontal dashed line, that's 100%. And if you take a percentage of that, you can see basically the same thing I've already showed you, is that it really went down in that first lockdown, April to June 2020, and then it kind of went back up and maybe went down a little bit, but not so much in subsequent lockdowns. We also were interested to look at whether any sections of the population were disproportionately affected, and actually we didn't find a big effect. So males and females, there are more females in the population and more females who undergo certification, and more females in elderly age groups. So that and AMD seems to affect more females than males for some reasons for which we don't fully understand. But we didn't see. We compared the distribution before, in the years before COVID with the years of COVID, and the percentage of males and females were very similar. Age categories were very similar. We were worried the elderly may be missing out on certification. Actually, the elderly made a statistically significant, it wasn't a very big difference, a greater percentage of certifications during the pandemic. So but there wasn't evidence of them missing out, and actually it fell for younger people. Whereas, and when we looked by ethnicity, there wasn't really a big effect. These are small numbers, so it's hard to know. There was a statistically significant change in the ethnic composition. There was a suggestion maybe that you had fewer Asians, so was it disproportionately affecting them? It's hard to say with such small numbers, because it's like 5% here, but we did see a small possible effect. Try and get my slides moving again. Yeah, and then if we were to look after COVID, this is, I've just moved things along, and here we're plotting the monthly certifications received by the office, 2019, 2020, that drop I've already talked about, 2021, then 2022, 2023, post-COVID pandemic. You can see it's come back pretty much to normal. We were wondering whether we'd see a big increase because of the people who didn't get certified before. We didn't see a big increase, and maybe it kind of just averaged out over the next couple of years. So we're just seeing back to sort of pre-pandemic levels. now in terms of certifications. It only goes to March 2023 because after that, England and Wales got separated. So Wales collects its own CVI data. England, so these numbers then are different. So you'll see a huge drop in England. That's because we haven't got the Welsh component. So that's why this chart only goes to March 2023. So now I want to talk about, and this is the main kind of nubbin of the talk, is current challenges in CVI. So there, and don't worry about whether you can read these, but these are just some papers, and there are others as well that have talked about a big issue is that there's lots of evidence that patients who are eligible to have a certificate of vision impairment aren't getting them. Now, it could be, obviously, it's a voluntary thing, and it may be a patient says, I don't want to have a certificate at this stage for whatever reason. And of course, it's not a compulsory thing, but the probability is actually it's not even being offered or being discussed. So there are some papers that looked at patients who seem to meet CVI criteria, but there's no record that they've been offered a CVI. And maybe they have and it wasn't documented, but it's probably good practice to document when an ophthalmologist sees the patient. And so whatever data we're getting from how much vision impairment there is from CVIs might be underestimating the problem. But more importantly, forget about whether the data is clean or not, patients who maybe could be really helped by certain avenues of support, they're not getting that because they maybe don't know about the CVI, they don't know that they're eligible, the discussion isn't happening. And so why isn't it happening? And so, you know, that people have shown in diabetes, in other conditions. One of my colleagues, Professor Roxanne Crosby Nwobi, who's one of our very active research nurses at Moorfields, did an audit and found that this huge proportion, there was no documentation that a CVI had been discussed, even though we can see from the visual acuity that was recorded in clinic that patient should have been eligible. Now, it could have been they had a CVI and it just wasn't documented. That's definitely possible, but it could also be it just wasn't on the ophthalmologist's mind. And many ophthalmologists are more concerned for obvious reasons about making people's vision better, treating patients surgically or medically, and we've got these big clinics and we have to laser this patient or list this patient for surgery, then maybe thinking about a CVI isn't always on our minds, but it needs to be because those patients who meet those criteria, that discussion should be had. And as we've said, a consultant ophthalmologist needs to sign off on it. There was another paper, a very innovative paper using an automated tool looking at visual fields to see if from visual fields you could see there was enough field loss that patient would qualify for a CVI. And again, it looked like many of those patients hadn't been offered a CVI, at least as far as could be gleaned from the data. And this was the subject of a In Touch. So many of you may be aware of this Radio 4 program, In Touch, Peter White, and dealing with issues to do with sight loss. And there was a program dedicated to it, which you can actually go to the website, but it was in July 2023, about delays in accessing essential services and including accessing CVI. And it's an important issue, and it was good that it came to prime time media. And I was asked to participate in that program to talk about things from the ophthalmologist side. I was a little bit worried about going on because, being like, why aren't these GIT ophthalmologists offering these? And here we have one of those here. And Omar, tell us why you're so bad, and your colleagues. But I felt a moral obligation to be on that program to explain the challenges and what we're trying to do about it and others to try and address this. So what are these sort of initiatives that are going on? I think we need to, we have continuous education, our ophthalmologists as they go through training. Maybe CVIs don't feature as a big part of training, and we're trying to change that. So an integral part of ophthalmology training is understanding the CVI. We have many international trainees, fellows coming from other countries to get experience here. It benefits them and it benefits us a lot. We learn from their practices elsewhere as well. But there needs to be a way of educating them about what what the CVI criteria are here, because it may differ from other parts of the world, and especially ramming home that it's not just visual acuity. Yes, visual acuity is one criterion, but if someone's got really good 6/6 central vision but a really bad visual field, affecting all of their vision apart from the very center, they would also be eligible, and not every ophthalmologist trainee is aware of that. Having reminders, so at Moorfields every few months we try to send out a reminder to all of our consultant ophthalmologists, just remember to discuss CVIs with eligible patients. Again, there's a challenge there because now we've got new ways of working, which are very good in some ways of dealing with backlogs and getting patients through clinics more quickly. They used to wait hours because they always have to see a doctor. Now we have virtual clinics where the patient just has some imaging done and then goes home, and then that's later reviewed by a doctor, and then the letter's done, so that makes it quicker for the patient, more efficient. But then you lose that contact where maybe that opportunity to discuss a CVI, do you have a certificate of vision impairment, do you know about it, then that opportunity may have gone. So we need to deal with what do we do about that. Having red flags, many hospitals use electronic patient records now, so we have now flags on our electronic patient record. If the visual acuity is below a certain level, then automatically you get a flag saying this patient might be eligible for a CVI, i.e. please discuss this. But people have got this thing we call flag fatigue. Now there are so many red flags in the, this patient might need this patient might need this, then suddenly you kind of get in, when you have so many and you've got a busy clinic, then it becomes easier to ignore the flags, which one shouldn't do. So we have to worry about that as well. Maybe there should be mandatory fields when you enter the patient's examination data in these electronic patient records. Maybe you shouldn't be able to go to the next bit until you've addressed CVI discussed or not applicable for whatever reason. Making the forms accessible. So many hospitals still have paper forms, and sometimes you're in a busy clinic and 15 minutes to try and find this form, where is it? And there's this kind of incentive to just get through things and maybe we'll discuss it at the next visit. No, having it accessible or available electronically and having your system not going down every so often is important, and maybe that could streamline these processes. An initiative that's happened in Wales, where they had very big backlogs and waits for patients to see ophthalmologists. So there were patients in the community who were not having access to CVIs when it could really help them. They had an initiative, involved a change in legislation allowing accredited optometrists who've done a certain amount of training to sign off on CVIs. And I think that will make a big difference to those patients in those areas. So could that be something? It's a bit more complicated to try and roll that out in England, and maybe the backlogs aren't the same, but maybe that would be part of the solution. And also, other challenges, sometimes it's very difficult to know whether a patient may have a CVI, and we just don't know about it. There's no central database because the central register has been anonymized for good reason. And so at Moorfields, one particular initiative led by a colleague of mine, Omar Mahroo, was to look at patient data retrospectively and try and electronically use a data-driven way of looking at all the patients who had visual acuity, their last recorded visual acuity was below a certain level. Is there any documentation anywhere in the record that a CVI has been discussed or that they've had a certificate? And if not, how do we go through that backlog? And now we have an automated way of flagging those patients to the ECLO when they come for their next visit, so that a CVI can be discussed. And I think that has been quite successful. It's quite a big piece of work, but I think it's yielding dividends in terms of more patients having access to support. And this was presented by Marco at the Royal College of Ophthalmologists annual conference a few months ago. The initial preliminary data we had from that project trying to improve patient access to CVIs by going through and trying to prospectively identify which patients should we discuss it at, and when's their next visit going to be, so that in a timely way we can send a reminder to the ECLO or to the consultant. So in the future, one new development is there's a new CVI form. Again, the easier a form is to fill in and to access, the more likely it'll be to fill in. So if it's very complicated and hard to find and confusing, then ophthalmologists may be less likely to fill it in. So if we can make it easier to do, as with any process, then let's hope that that'll improve things. So there's a new CVI form that's currently with the Department of Health, and we're hoping that that might improve things, trying to streamline processes within hospitals and within the community so that eligible patients are flagged up and the discussion is had. Initiatives to improve awareness. So I don't usually talk about CVIs myself, in terms of when I give invited talks, normally about my research or inherited retinal disease, but I always put something about CVIs in those talks now so that people are aware that really it can make a huge difference to our patients, and not to neglect its importance. And then the Welsh experience, as more data comes through, we'll see what difference that made with accredited optometrists signing CVIs. So just to conclude, CVIs, as I said right at the start, are an important enabler to access support, and they're an important data source for us understanding, is blindness increasing or reducing, vision impairment, how is it changing, and are the causes changing with time, so that we can know where to allocate research efforts or health resources. We have all these initiatives that I've mentioned to try and improve CVI uptake. We have to also be aware that if those initiatives are successful, it won't mean that blindness has gone up. It'll mean that it's actually a success, that patients are now accessing support, patients who weren't able to access it before. So there's a slight conflict between those objectives, because we're using it as a data source to look at trends in vision impairment, and then suddenly, hopefully, we'll see an increase as more patients access support. But in the long term, those goals will hopefully align, because if we have more patients who are eligible accessing CVIs, then the data in the longer term will be more reliable, and it will really reflect vision impairment and its causes in this country, so that hopefully it can guide us in terms of allocating resources to do something about it for the good of the nation. So those are those two publications. Again, I'm happy to send anyone the links. These are some very good web links on the RNIB website and the Macular Society website that give more information about the Certificate of Vision Impairment and benefits of registration. A certificate is the certification, and the registration is what happens with the local authority, but the certificate can facilitate the registration. And with that, thank you very much for listening, and I'm happy to take any questions.
Thank you so much for such a really interesting talk. And those links you shared at the end, we may have shared some of them in the chat already, but if not, I will, as we're talking, I will get hold of them from your presentation and share them in the chat. We've had a few questions come in, but if others have got questions, please do type away in the chat, and we will get to those as soon as we can. We got a couple of linked questions. One is, how bad does your sight have to be registered sight impaired or severely sight impaired? Very similar question, someone asking what's the criteria, and does it have to be in both eyes?
Yeah, absolutely. So yes, both eyes. So someone could have lost complete vision in one eye, which obviously is a vision impairment. No one's arguing that, of course. But if the vision in the other eye is completely normal, then they wouldn't be eligible for a CVI. It takes your better seeing eye, if you like. In terms of the criteria, and you can find them on these websites, it's a little bit nuanced, because there are different aspects to one's vision. So the simplest criteria are the visual acuity, which, as you know, we measure with our Snellen charts, and 6/6 is 20/20 vision, normal vision, what a normally sighted person could see at 6 meters, you can see at 6 meters. If your vision is 6/60, or less than that, then you're eligible to be registered as sight impaired, or have a certificate of vision impairment, sight impairment. And that means what a healthy person could see at 60 meters, you need to be at 6 meters to see. And if it's even worse than that, less than 360, so that same size letter, you can't even see at 3 meters, then that would make you eligible to be registered as severely sight impaired. However, that's only one part of the story. Because that visual acuity doesn't capture all of vision, your visual field is also taken into account. So part of the reason it's kind of slightly been not set in stone, I think, is because it's left at the discretion of the consultant ophthalmologist because there are so many different factors that can affect someone's vision. I deal with inherited retinal disease where someone can be 660, but they've got widespread what we call cone photoreceptor dysfunction, so they can't even go out in normal daylight. So that's a lot worse than someone who's 660 who'd otherwise have a normal visual field. So someone could be 6'6" in their vision, but their field of vision is tiny from glaucoma or retinitis pigmentosa or another cause, and they could be eligible to be certified as sight impaired or severely sight impaired. So those are the visual acuity criteria, but there are other criteria like if your field is down to 5 or 10 degrees, then even if your central vision is very good, you could also be eligible.
Thank you. Um, you've obviously talked about data within England and Wales. There's a question of records kept for Northern Ireland as well.
Absolutely, yes. So there's a similar process in Northern Ireland and in Scotland as well. And there's someone called Jonathan Jackson who's done a lot of work with the certification in Northern Ireland. They had that same issue many years ago of they seem to have a much smaller proportion of certification compared to in England and Wales, and it could be because no one has any sight problems in Northern Ireland, but they suspected it because there was, reduced access for some reason, and they addressed that, and now they have a similar rate to England and Wales, and records certainly are being kept for Northern Ireland, but not at the certification office in London. They're kept in Northern Ireland, and similarly with Wales since 2023. England and Wales, the data collection was separated, so Wales now collect their own data, and now the data collected in London is just for England.
It's one of those wonderful challenges of devolution there.
Yes.
Slightly different approaches and slightly different data collection methods in different nations. Um, I wonder what the most common misconception is that patients have about registering as sight impaired. Do you have any insight into that?
Yeah, I think there's a few things. One is that it would prevent them working, and that they have to declare it to everyone, like wear a badge. I've got vision impairment, and that's certainly not the case. Patients don't need to tell anyone they don't want to about it. Obviously, the DVLA is a different thing. So someone who's registered sight impaired, that's an important thing to be aware of. That means already the vision doesn't meet the driving criteria. So sometimes I do get questions from patients who are eligible to drive, and automatically, the fact that they can drive means that vision isn't fortunately that bad. And if they were to have a CVI, it means they wouldn't be able to drive. But otherwise, patients don't have to inform anyone necessarily about it. Other misconceptions are that it's taking resources away from others. I've heard. I see it as if you're entitled to something, then you don't have to claim anything. You can, and it's still a voluntary process. You still don't even need to get the certificate, but having a certificate, and then you can decide what you want to, what you may be entitled to. Obviously, it's not just the certificate. Then in terms of support available, there are other things that are looked at, like your visual acuity, and there are different departments that look at different things. It's not just the certificate, but certainly the certificate is usually helpful. Another thing I find is and everyone's psychology is different, but sometimes, especially if patients dealing with the bad news for the first time, that I've got a sight condition that's not treatable. Obviously, understandably, that's a lot to process, and then to have a certificate as well when previously maybe they thought their vision was going to improve. So I think it's a big, so I never and my colleagues, we never push anyone into it. Certainly, we just try to raise it as a possibility. And my own practice is to give the details of our ECLO, our eye clinic liaison officer team, who are excellent at more fields as in other hospitals, and then the patient could discuss it with them. And then if they decide later, having thought about it and what it might involve, then they don't need to come back. I've already made a decision that they would be eligible. I've written that in my letter, so that if they then come back, I can just sign it from my side, and then the ECLO will send it to the patient. So certainly, there's no urgency about making a decision. Like patients, and I think if I don't decide now, I'll never. It's now or never. That there's always that possibility of deciding later. But I do find some people see it as something that they have to process, and they want to take a bit of time over.
Yeah, you mentioned driving, and I saw a comment from someone saying they actually went through the process of getting a CVI so that they weren't tempted to go on driving, which I can
Yes.
understand might be an approach, a very sensible approach. If you're concerned you might not be safe to drive, it's important to make sure you don't. Um, in terms of who can issue a CVI, someone's asked, is this something local opticians can do, or is it just something doctors can do?
Yeah, so in apart from Wales, but in England it has to be an ophthalmologist, and Scotland and Northern Ireland, I believe as well. But Wales has this new process now where accredited optometrists can. But if you so if someone if you think you might be eligible, you want to have the discussion, then the way to see an ophthalmologist is you can see your GP and ask to be referred in. If you wanted to know quickly, and I see some people have said that in the chat, absolutely. The optometrist, I think, is a good first call because, as we know, you can go to high street optometrist and be seen very quickly. Unfortunately, many hospitals have backlogs, so unless something's sight threatening, you get processed routinely and might not be seen for several weeks. But you could ask your GP for a referral, and they should be able to refer you to your local eye department. But if you want to know, most optometrists know about CVIs, and so if you wanted to know what's my level of vision, that might be a quick way of finding out.
Thank you. And that, I think, answers one of the other questions. How do you get to see a consultant and they haven't seen one since diagnosed with wet AMD 18 months ago, although it looks like they are receiving injections, I think they're saying. So presumably you could speak to your GP if you're not under the care of an eye clinic, but if you are, you would request that through that clinic, presumably.
Absolutely, absolutely, yes. I think if you're being seen for injections, even if you're not seeing a consultant there, you could ask the staff there because they'll be linked to an eye clinic, and absolutely, they usually there are consultants in charge, even if you don't see them of those big injection clinics. So they're lurking somewhere, so they'll either come out or you could see them next visit or something like that. There should be some way, but if you're not already under an eye department, then seeing your GP might be the way.
Yeah. And sort of similar topic, I guess someone said with people with dry AMD, they usually never visit an eye clinic. Is there any research on how to reach that group of people?
Absolutely. If you have dry AMD, then and you're wondering about certification, definitely, if you're not under an eye clinic, ask your GP to get you referred in. If you want to know, because dry AMD can encompass a whole range of visions, you might want to see your optometrist. That might be easier to see them. Just say, look, what's my level of vision, and would this meet the CVI criteria? And they may be able to tell you, or you could see what vision they've recorded for you, and then go and on the web links that have been put in the chat and see if you meet those criteria. But definitely, you can ask to be seen, and absolutely, because unfortunately at the moment we have no treatment for dry AMD, so many of those patients did get discharged, but that conversation should be had if it hasn't been had already. And there are other ways the eye department can help. They can refer you to an LVA clinic that might be able to optimize what vision you have. So it is worth, if you haven't been seen for a while, getting seen.
Thank you. You've obviously talked a lot about the sort of data collection element. How do you see that informing service improvements and making a difference to people?
Yeah, I think that's right. So one thing in terms of I don't know if it is as seamless and joined up as it should be, but I think understanding the big causes of blindness might inform us in terms of how many different types of ophthalmologists we may need, or how many ophthalmologists we need, or eye care professionals we do need in the population. There's a workforce review. Governments often do workforce reviews, and I think the recommendation from the Royal College of Ophthalmologists is a certain number of ophthalmologists per unit population, and we're not quite there. And in some parts of the UK, it's even lower. So I think being aware of that, and then in terms of the different ophthalmic subspecialties, I think it's recognized there's a dearth of pediatric ophthalmologists. There's something about pediatric ophthalmology that maybe not everyone wants to go into it, but maybe we need to encourage people because there's a huge amount of sight loss there that we need people specialized in. So I think knowing how much sight loss there is can inform what kind of resources we need, including ophthalmic subspecialties, as well as LVA clinics, and it can be even used to measure the success of things like diabetic retinopathy screening, and or whether that needs to be tightened up, or we're not reaching reaching certain areas of the population. I see it as a stimulus for, unfortunately, most inherited retinal diseases are untreatable, and people often think of them as very rare conditions. But when you realize that the biggest cause of CVIs in the working age, then actually they are very important. And so just knowing that can be a driver for funders to put some investment there. These aren't just rare esoteric conditions, but somewhere where resources are needed.
Yeah, this sort of evidence is so important, particularly for organisations like the Macular Society, when we're, meeting with policymakers and trying to highlight how important macular disease is and how important it is that the right service is there. So yeah, data, it often stems from data. Um, I'm just looking through, making sure we haven't got any other questions that I've missed. At what stage do you think someone should consider applying for certification, and do people have to wait? Do people wait longer than they perhaps should? Do you feel?
So it's variable. I have to say, I think some people. I mean, everyone's life is different, so we try not to be prescriptive. You must apply at this, but I think it's worth considering whether it may be helpful. We often, so right from the younger ages to older ages, it can help. Certainly in our pediatric clinics, we try to get certification and education support and family support in early, because that can make a huge difference to that child's trajectory through life. They may have a rare inherited retinal disease, but if they can get all the educational needs they have, they can, maybe achieve things in life that they wouldn't otherwise. And sometimes that isn't actively looked for. Someone can't see the board properly, and the teacher thinks they're not paying attention, and but actually they just can't see properly, but they don't realize that their vision's not as good as everyone else, and they just lose interest. And so I think those sorts of interventions early are really important. But then at any stage, in the working age, sometimes adaptations can be made which the CVI can facilitate. It doesn't have to. I mean, many employers are good at adapting to people's needs, but sometimes a CVI does help, and so it's not something that maybe should be left, because it could really improve your working life and help your employment situation if you had the certificate. And similarly, right through to the elderly, our biggest cause is AMD. I think having that certificate can provide access to support and local support, often with the SSI. That tends to allow you, for good reason, to access more in the way of support. Then I think there's no real good reason to put it off. But at the same time, I know it's something for people to process. And I find a variety. Some people, when I mention it, yes, absolutely, I'd like that. And some people, I'd like to think about it for a bit, and that's absolutely fine. But I can't think of any advantages if one's eligible for putting it off. They can decide what they have later, but having the certificate, if that's your eligibility, then and no reason perhaps to delay that.
Yeah, no, it's often the way I think with these sorts of things that are about adapting to a health condition. Understandably, people don't want to embrace it, but often once people do, it can unlock that support which is available. And I should say I shared those links in the chat a little bit earlier. Hopefully, people can see those and click on them to the links that you shared in your slides. And colleagues are also just sharing a few useful things. You mentioned this Welsh model where some optometrists can give CVIs. Is that something you would encourage us to explore in England or
Yeah,
elsewhere in the UK?
Yeah, I think so. So we did, again, Roxanne, my colleague, did do some pilot work to look at agreement between allied health professionals and ophthalmologists once they'd had some basic training. And, maybe some conditions are quite specialized even for ophthalmologists to understand them fully. But things like AMD, certain inherited retinal diseases, glaucoma, you can see, a certain amount of field loss. You shouldn't necessarily have to be a consultant ophthalmologist to determine a patient as eligible. For certain reasons, things seem to be a bit harder to get through in England, whereas I think the devolved governments can be a bit more nimble in certain areas. Although I would also say that I think the backlogs in Wales the waiting, it's not perfect anywhere in the UK, but the wait to see an ophthalmologist is lasting years in some areas of Wales, and that's really tragic, and really needs to be addressed. So there, I think you can see a huge benefit of someone, at least those who it's really just for the certification. Having an optometrist, sometimes they have to, again, the distances in Wales, in rural Wales, can be a lot longer to travel to the hospital eye departments, whereas an optometrist may be more local. You can see a real benefit, whereas maybe with England, the population structure is a bit different, and the backlog in terms of seeing ophthalmologists in most places, thankfully, isn't so bad. So perhaps other, maybe a bigger problem lies in just the ophthalmologist thinking about it when they see the
Right.
patient in clinic, or having a system where the patient's under the eye department, but a CVI is discussed, and maybe that certainly is a big part of the problem, rather than the backlog maybe to see the consultant ophthalmologist.
Right. Brian said they've been told they cannot drive and have wet macula in both eyes, but their consultant won't register them as partially sighted. Is there any advice you can give them?
Yeah, so it's hard to comment on particular cases, but usually, there's that visual acuity requirement that I mentioned, but there is a bit of discretion as well. It may also be that ideal more with inherited retinal diseases now than wet macular degeneration. Often when people can't drive, it's because their visual field is impaired, and that would qualify you to be registered sight impaired. Similarly, although you may not be 660, if there's quite a bit of central involvement, and especially if it's like affecting your inferior field, so we say, if people lose vision up there, it doesn't tend to, unless you're a bird watcher or something, it doesn't maybe tend to affect one's life so much. But if you lose vision sort of below your fixation, you're more likely to trip over. So an argument can be made. Again, it's hard to comment on your particular case, but in many places I know, and we certainly in our inherited retinal disease clinics kind of use driving as a threshold. If you're not eligible, then probably it's worth considering being registered partially sighted. So again, it's hard to be completely, say, oh, he's not doing the right thing, but it's something where we would definitely consider it. So I think it is worth a discussion.
Okay, thank you. I'm just checking. I don't think we've had any further questions come in, so I might just wrap up on a kind of forward-looking one. What's the one change you would most like to see put in place for the certification system in the next few years?
Well, so probably all of those things. I mean, I'd like it to be kind of seamless in the hospital eye department, so that it's very easy to arrange a certification. I'd like it to be integrated in ophthalmic education. I know I'm speaking mainly as an ophthalmologist, and there's lots of other things that can be done. But I think that I've been myself in those positions where in a busy clinic and you can't find the form, and you've either got to make your patients who are outside wait even longer, or you've got to go spend 10 minutes looking for the form. So having that kind of setup where it's electronically available, digital, easy. The systems are robust, so they don't keep going down. We had something similar at Moorfields where they introduced a new electronic record system, and you could see our certifications went down for a few months and then, bounced. And that shouldn't happen. That's, seems to be something that should have been totally preventable. That kind of thing I would like not to see. So having robust systems where we have a seamless way of people having access to CVIs, I think that'd be one thing that would really benefit patients.
Good. Well, that's a nice kind of forward-looking point to end on. So thank you so much. A really, really fascinating talk, and thank you for covering such a kind of broad range of questions. And yeah, really, really interesting to hear from you. Next month will be our final webinar of the year, because we'll be getting very much into the Christmas season, and that will be taking place on the 18th of November. At the usual time of 7 p.m. We haven't confirmed who's joining us yet, but we will share that information in the coming weeks. So please watch this space. And with that, I'll say thank you once again to Omar. Really, really good to speak with you. And thank you to everyone for joining us, and hopefully see you again next month. Take care. Bye.
Thanks very much. Bye-bye.